killing yesterday. Other than cell killing, another one is chromosomal aberration. Third one is mutation induction, mitotic inhibition, and division delay. So we'll discuss other four from chromosomal aberration to division delay today. I'm not going very detailed. What is chromosomal aberration? Aberration means certain abnormalities or changes happen. The radiation-induced chromosome damage is the chromosome aberration. So it can be two ways. Number one, the first way is numerical changes and or the structural changes. Again, you please go back. Where is chromosome? You have the cells, that is your animal cell, and there is a nucleus. This is the most important part of any cell. Every cell has one nucleus. One nucleus has 23 pair of chromosomes in human body, 23 pairs. 23 pairs, 46 number of chromosomes. So you can see 23 pair of chromosomes inside the nucleus. Each chromosome has many number of DNAs. DNAs are stacked with a histamine protein, then chromosomes are formed. And one DNA is a nucleotide. It consists of a sugar, phosphate, and bases. So any changes, structural changes happening to the chromosome is a chromosomal structural aberration. Any number changes because of radiation. Number changes means sometimes when some of the chromosome get deleted or loss of chromosomes from the nucleus, or gain of chromosomes, multiplication, chromosomes will repair and it may act as a new chromosomes as a gain. This is called a numerical aberrations. Example for numerical aberration, Down syndrome. Instead of 46, sometimes it comes 47 chromosomes. That is called a Down syndrome. Structural changes, if you go, there are different abnormalities. Number one is called the deletion. It's very, very easy to understand what is deletion. I just draw the picture of one chromosome. For example, this is the central part of the chromosome we call it a centromere. So this is called what is this called? Chromatids. So a chromosome looks like this. Inside these chromatids and all, lot of DNA sequences. So this is adenine, thymine, bases, etc. are coming here, where your genetic information are stored inside this base pairs. Now, and this portion is called a telomere. And of course, one chromatid is longer and other one is shorter. Suppose because of ionizing radiation, a single strand break or some break happened here or here. Chromosome is deleted. This is called a deletion symbol. Another one is called a restitution. Restitution is not actually, finally it's a repair. Some deletion happens and after that this strand, the broken strand will get it resolved. That is called a restitution. Deletion, then it repair. That is called a restitution. Another one is called a translocation. Translocation is this chromatid you see, this is arm 1 and this is arm 2. Now there is another chromosome, similar way. And sorry, this chromosome also, suppose this is getting deleted and this is getting deleted from here, this pair. Now, after repair, this will go to here and this will go to here. That is called a translocation. That can also happen. Translocations can come in different ways, like ring chromosomes, dicentrics, etc. Dicentric formation is one of the important chromosome damage. Here, this centromere, some part of the chromosome chromatids here deleted. There is another one here also. This part is again getting deleted. Now, while trying to repair, there are chromatic portions here and here. But while trying to repair, the cells cop up something like this is getting repaired here and this is getting joined here. Now, the additional things like the chromosome will have two centromere in a single chromosome. That is called a dicentric formation. Two centromeres in a single chromosome. And this is the one which is being used for the biological dosimetry. For the biological dosimetry, we collect the blood samples and they take the counts of dicentric formations. So which is something like a gold standard for cytogenetic test, this dicentric formation. Ring formation is also ring chromosomes, similar concept. Sometimes this portion got deleted, and this can come here and repair it. It looks like a ring. So that is called the ring chromosomes. So these and all are the different structural changes that can happen with the chromosomes. And third, cellular level effect is mutation induction. What is mutation? Or what is mutation induction? So mutation induction is something like the changes that are introduced to DNA sequences. That is, whatever the damage, it's a simple damage. But after the damage, certain changes will happen to the sequence, DNA sequence. That is called a mutation induction. I will tell you what is that. If there is a mutation induction, what happens means the hereditary changes will happen. The informations which is stored will be spoiled. It is getting like a wrong information will be stored. Genes will be like, the genes will get corrupted. Okay, so there is a study. If you increase the radiation dose, then mutation induction is also increases, just like cell killing. Mutation induction possibility is higher. If you see the mutation induction, there are two types. One is called the chromosomal mutation and gene mutation. Chromosome mutation is the result of chromosomal aberration, something like what we have discussed. And after that, the code has been changed, and that is the mutation, structural or numerical. And see, whenever there is a chromosomal aberrations, most 100% it may not be a damage. It can repair sometimes, and sometimes it can stand there. But if there is a mutation, means the sequence is changed because of that damage, then that is called a mutation. Large segments of DNA or whole chromosome is changed, sequence is changed, then that is chromosomal mutation. Now you just come again inside the chromosome. There is a chromatids and there is a DNA sequence. Suppose there is a DNA changes, inside the DNA changes, it is called the gene mutation or point mutation. Exactly how it is, I will tell you. Suppose you have the whatever we discussed yesterday, adenine, thymine, guanine, cytosine, these things are there inside the DNA. Suppose the mutation, suppose one thymine is deleted, cell could not do the repair. Okay, if there is a cell death, that is different issue. Sometimes there will not be death, but this is faultily, it comes, something else will come here and it is coded. Now a wrong information is coded here. Cell will survive, but it's wrong information has gone. Now that is going to pass as a mutation induction, and it is going to as an hereditary effects in the next generation. So point mutation is something like very point in between base sequence and small areas. Whole chromosome is mutated means chromosomal mutation. Now point mutation can be two types actually. One is called the base substitution. Simple. You have purines, adenine and thymine. Base substitution can be transition or transversion. Transversion is, you know that, what is that? 1 second. Yeah. Adenine, thymine is linked. Guanine, cytosine is linked with the three hydrogen bonds, and this is with the 2 hydrogen bonds. So for the transition, the purines get replaced with another purine. That means adenine is replaced with the guanine. Both are purines. It never happened, but because of mutation, A-G bonds, that is called a transition. Transversion means adenine should be thymine, but cytosine also a pyrimidine. So instead of thymine, cytosine came here. So that is called adenine versus cytosine. Actually, it should not be there because cytosine should always come with guanine. But sequence is changed here. This is called a transversion. And frame shift is like something is deleted in between, so the whole frame has been shifted. Instead of something, complete code is different. So these are the different mutations which can come because of the irradiation, mutation induction. Now, the next thing is mitotic inhibition. What is mitotic inhibition? You know what is mitosis? Mitosis is the cell division, mitosis or meiosis, whatever it is. So because of radiation, decrease in the percentage of cells in the mitosis due to radiation, that is called the mitotic inhibition. This is something like shown by certain cells when it is irradiated, especially the time of mitosis. So how it happens, because of the blocking of cells in G2. I'm just taking you back in the yesterday's slide. See, cell cycle will has a, as we said, there is a cell cycle, cell division. There is a mitosis here, then G1, then G1 block, then there is a synthesis S phase, and this is G2 block. Okay, so division happens here, and all this time the cell will getting prepared for next division. DNA synthesis will happen for the next division. So what will happen? As we said, sensitivity of cells towards radiation is different for different cycle, different phases. Because of irradiation, the mitosis will be slow. Because of irradiation, the cells in the mitosis phase will getting blocked there. And sometimes what happens, some of the cells in the M phase will revert back to G2 phase. So there is a delay, and this is called the G2 block. So the average time interval for every phase is already defined for cells. But there will be a inhibition in the mitosis, and there is a delay because of all this G2 block. It is called a mitotic inhibition and division delay. So this is the another cellular level effect of ionizing radiation. Now the next topic is law of Bergoni and Tribando. This is also something very simple to understand. Law of Bergoni and Tribando says it's a law. It's representing the radio sensitivity of different cells, because we know that different cells will have different radiation sensitivity. If you take spinal cord, if you take brainstem, if you take nerve cells, if you take muscles, if you take lymph, whatever this WBC and all, these and all have different sensitivity towards radiation. Now, how can we understand, or how can we discriminate or classify these cells in terms of radiosensitivity? Now, this law says that the sensitivity of any cells towards radiation is directly proportional to the reproductive activity. Reproductive activity means if the cells are more dividing, they are more sensitive. Every cell division is not same. Certain cells will divide very fastly, certain cells will divide very slowly, certain cells will not divide and will not regenerate. So most rapid cell division, if the cells are dividing fastly, they are very high radiation sensitive. Okay. And another thing is, the second thing in the law is, if the cells are very primitive, they are also very sensitive. We'll discuss those things. And this law can be applied almost in all cases, but there are a few exceptions. That also we can see later. So according to this, cells are radiosensitive, you can say, if they have high mitotic rate. High mitotic rate means high cell division, high probability of cell division. And second thing is, if they have high mitotic future, if they don't divide regularly, but they can divide for a long time. After a few long years also, they can divide if it is required. That is long mitotic feature. And third thing is, they are primitive, they are least differentiated. They are base cells, then they will show high sensitivity. Now, high mitotic rate example, as I said, rapid cellular division. You can get the examples of bone marrow cells, basal layer of epidermis, intestinal crypt cells. These are all high fast dividing cells. They are highly radiosensitive. And long mitotic feature, best example is liver. Liver cells are not dividing regularly. They are not fastly dividing, but they are a capability of division if required. Suppose if you cut the liver tissue, then there is a requirement. Then the liver start to divide and regenerate it. So these cells are also sensitive. Of course, the first place goes to the high mitotic. Then if you compare the liver cells with the liver cells are better radiosensitive than nerve cells, because nerve cells are not at all dividing and they don't have any long future division possibility. And the third possibility that we have primitive cells. What are primitive cells? Let us take an example of the sperms or the reproductive cells. The base cell is spermatogonia, that is stalk cell. They divide, then they convert to spermatocytes, then spermatids, and the sperms are the final things. So the sperms are the highly functional cells. This process is called a differentiation. Spermatogonia is the stalk cell. Sperms are the functional cells. So this is the degree of the way of how it is formed. Now, law of Bergoni says that if the cells are primitive, they are more sensitive than a differentiated cell, than a functional cell. To understand that, if you take spermatogonia and the sperm, spermatogonia is more sensitive than sperms. Okay. Similarly, example, bone marrow cells. Bone marrow are the stalk marrow. Then once it differentiated, once it divide, then erythroblast come, many division, undergo many division, then RBC forms, many division, myelocytes, many division, granulocytes, bone marrow, again, megakaryocytes, many division, platelets. If you take bone marrow and RBC, bone marrow is more sensitive than RBC. But there is an exception here. You need to apply that exception. In the case of lymphocytes, lymphocytes are a type of WBC. They are functional cells. And they're also coming from bone marrow. But if you take the case of lymphocytes, even though they are functional or highly differentiated cells, they are highly sensitive than bone marrow. So lymphocytes are said to be the highest sensitive cells in the human body, radiosensitive cells. Okay. So according to this, you can classify the cells, the mammalian cells, in terms of, four category. One is called vegetative and intermitotic. Intermitotic means regularly dividing. Vegetative means they are not differentiated. They are primitive cells. This is the highest category of high sensitivity group. Second sensitivity group is differentiating and intermitotic. Intermitotic again dividing, but they are functional, not primitive. Example is the lymphocytes, WBC. And the third category is postmitotic. They don't divide regularly, but reverting. They can divide if required. And the fourth category of cells are fixed and postmitotic. They are not divided. Their division is over. They don't divide, and they are also fixed. So these are the examples for this type of cells are muscle cell, nerve cells, etc. So according to the law of Bergoni and Tribando, the most radiosensitive cells are lymphocytes, and most radioresistive cells are nerve cells and muscle cells, according to this theory. Now, classification of radiation damage. How do you classify the radiation damage? Lethal damage. You know what is lethal damage now. These are irreversible, irreparable, and leads to the cell death. That is called a lethal damage. Sublethal damage, which can be repaired in hours most of the times. Sometimes sublethal damage, if one SLD happens, another SLD happens very soon, then it cannot be repaired. It may misrepair. So it is like it can be repairable, but it may not be repairable all the time. And potentially lethal damage, we discussed yesterday, the repair mechanism can be active because of the certain type, like if you provide certain situations. Otherwise, it is a damage. These are the three types of damage theoretically. Now, type of radiation damage, again, harmful effect of radiation may be classified to two general categories. All of you know, I am sure that one is stochastic effect and non-stochastic effect. What is stochastic effect? It is the effect in which the probability of occurrence, it is a probabilistic in nature. There is no threshold dose. It may happen, but it's not simply like a probability, but the probabilities depends on the dose. If more dose, more probability to occur. The severity of effect do not depends upon dose. That is the example of stochastic. That is the best way of understanding stochastic effect. Example, if a person is getting certain dose, let us think he is developing cancer because of that radiation. Another person is getting heavy dose. Let us assume he is also getting cancer because of that radiation. Now, the second person, we cannot say that the second person will be the stage 4 cancer and first person is stage 1 cancer. Nothing like that. Severity is nothing related to the radiation dose. But the probability of occurrence, the chance of getting that the effect is more higher with the higher radiation. That is the stochastic effect. Deterministic effect has definitely a threshold dose. So the effect will after once you exceed that threshold dose. And the severity is also proportional to the dose here in the case of deterministic effect. Another type of effect is somatic effects and genetic effects. Somatic effects, again, if the irradiation happens on somatic cells, Somatic cells are the any cells other than germ cells. Germ cells in the human being is either this one, sperms or ovum. Any other cells, if it is radiated, the things which is happening, even it is cell death or whatever, chromosomal aberration or whatever, it affects on that particular individual, then that is called a somatic effect. Cancer is a somatic effect. It's not a genetic effect, actually. If it happens on the same individual, same person. Genetic effects, it happens when the germ cells are irradiated and the victims are offsprings, the next generation. That is called a genetic effect. So how do you say about cancer infection, carcinogenesis? It's a somatic or genetic effect? It's a somatic effect. It's an early effect or late effect, cancer. Can anybody say? Cancer? Cancer is somatic effect, is it? Is it early effect?
Anybody can answer?
Late effect.
Very good. Late effect, somatic effect, and in terms of stochastic or deterministic. That also you say. Is it stochastic or deterministic?
Stochastic, sir.
Okay. So the better understanding is here, cancer is a late somatic stochastic effect. Is it? That is the very, very, I mean, if you go through the all effect, cancer is a late somatic stochastic effect. Type of, again, radiation damage, again, you can take in another way, like acute effect and late effect. Acute effect is something like the effect occur just after exposure. Inflammation, edema, hemorrhage, etc. If the effect is delayed, maybe generic, the delayed effect is called a late effect. Cancer is a late effect, actually. It's not acute effect. It can be late effect, can be somatic or whatever, this thing, stochastic or non-stochastic. But late effects, something like the only definition is if it happens after certain period, latent period, that is called a late effect. It can be stochastic or non-stochastic. That we don't, it can come in both ways, actually. Now, what is the effect of whole body exposure? Suppose a person or somebody gets a whole body exposure. What is the effect? How it is going to affect? So here we are discussing the syndromes. You know that NVD syndrome, bone marrow syndromes, etc. What is actually a syndrome? What is the meaning of syndrome? Syndrome is a collection of symptoms. If you have a symptoms like vomiting, nausea, etc., or if you collect some particular symptoms, then you can say it as a syndrome. The first syndrome observed is NVD syndrome. You know the full form: nausea, vomiting, and diarrhea. That is called NVD syndrome, radiation sickness. So symptoms: fatigue, headache, lack of appetite, etc. So it can happen within minutes to few hours. Yesterday we discussed that. So syndrome is a biological stage, biological effect. Physical stage, physicochemical stage, chemical stage, and biological stage. So this expression of syndrome is a biological stage. It can happen in seconds, minutes, hours, days, etc. We discussed yesterday. So here, the possibility, the future, like what happens once the syndrome starts? Mostly NVD syndromes persist for a few days, 1 to 2 days, and you can recover. Another syndrome is hematopoietic syndrome or bone marrow syndrome. Two names are there: BM syndrome. Its threshold dose is 2 to 3 gray, resulting in killing of large number of bone marrow cells. Number of RBCs, WBC, and platelets become less because bone marrow cells are the stem cells, primitive cells. So once the stock, if we irradiate it, the production of WBC, RBC will stop for some time. Again, it starts later. Threshold dose is 3 to 5 gray, or symptoms start 2 to 3. There are like certain difference, a range of values for threshold here. Anemia, tissue hypoxia, infection, fever, etc. are the symptoms. And usually you see LD 50-60. That means 50% of the exposed individual will die within 60 days. That is the effect of this syndrome. And gastro-GI syndrome is another one, which affects on your gastrointestinal system, your gut tract and digestive system. Mainly esophagus, stomach, small and large intestine, rectum, etc. As you know, radiosensitive cell is one of the cell is the Crypt cell, intestine Crypt cell. Their main function is absorption and digestion of food. So, of course, there is a fluid loss, electrolyte imbalance, low BP, circulatory collapse, etc. can happen as a symptoms, and death possibility is there for within 1 to 2 weeks. Now, whatever I am discussing is whole body acute exposure, whole body acute exposure, whole body, not partial body, whole body acute exposure. Then CNS syndrome, threshold dose is greater than 25 gray. Nerve cells will damage. So recovery is not very easy here. So death can happen soon. That is the CNS syndrome. Partial body exposure also various symptoms are identified. Skin is one of the biggest organ and one of the most important organ once we do the treatment or once we do the handle with radiation, because radiation comes inside through the skin only. So partial body skin exposure there are certain symptoms or symptoms can happen. You can say transient erythema. Erythema is the color change, reddening of the skin. Temporary is there or permanent erythema. Then what is called epilation. Epilation is the removal of hair. 6 gray, 3 gray, etc. are the threshold for this. Then there is 10 to 25 gray skin, dry desquamation, wet desquamation, necrosis, all this can happen. And interestingly, Chernobyl accident, that Chernobyl accident, the nuclear plant explosion happened in Russia. Today is, I think, Ukraine. And major skin burn due to beta emitters there. That skin burn happened because of high radiation. So acute partial body exposure, another important organ is reproductive system, reproductive organs, gonads, testes in males and ovary in female. So the limit is comparably very less, as you know, because of the high sensitivity of these tissues. 0.15 gray onwards, the sterility can start. Of course, it may be temporary. Males, 1 gray is assumed to be the temporary sterility. It can vary. Again, 5 to 6 gray permanent sterility. Entire stock of spermatogonia will die. Once the entire stock spermatogonia die means the permanent sterility will happen. Female sterility depends on their age because of the ovum, like oocyte production. The stocks are different at different ages. Generally, 2 to 3 gray temporary sterility and 5 to 6 gray permanent sterility depends on the stock of the oocytes, actually. Late effect of radiation, as we said, these are effects appears months or year after exposure. That is the late effect. There is a latent period always we say. What is the definition of latent period? It is the time interval between exposure and the expression of the symptoms or whatever. So that is the latent period. So there will be a latent period for late effects. Late effects can be, as I said, somatic effects, or it can be deterministic late effect or stochastic late effects, etc. These are the examples for that. Various late effect of radiation, malignant disease, cataract, genetic damage, lifespan shortening, etc. Now, one of the late effects that always we all bother is the cancer induction, the radiation-induced cancer induction. So dose-response relationship for cancer induction is actually well studied. At the high dose and dose rate have been well established. There are a lot of studies happened from Japanese population, animal studies, clinical data, other radiation accidents and all for establishing a dose curve, dose relation, the cancer induction versus dose response curve. But whatever we are lacking is we don't have a very established relationship for low exposures, like those resulting from diagnostic and occupational exposures. But still, we cannot neglect those because it's a stochastic effect. So it can trigger with any dose. There is no threshold of a stochastic effect. So we cannot neglect or we cannot say that it won't happen there. So another very important thing for the study of the cancer induction is that even we may able to get the incidence of cancer induction with the low dose, but the challenge here is the natural incidence of cancer is too much. So we cannot discriminate. Natural incidence is high. That number is high. So, and another challenge is the latent period is also there. So once the exposure happened, it won't come very soon. There is 8 to 10 years or 12 years of latent period for cancer induction. So these are the challenges for getting an established curve for low dose and low dose rate cases for cancer. The dose response curve. Studies showing evidence of carcinogens in humans. What are the studies taken for these studies? Carcinogenesis of radiation carcinogenesis. Of course, atomic bomb survivors, leukemia, thyroid, breast cancers were reported. Marshall Islands, some islands in Pacific Ocean where certain things happened because of nuclear weapons. Radium dial painters and all, or iodine 131 therapy for thyroid. These are the sample data collected for the studies. Now, dose response curve also been formulated. There are different dose response curves available for cancer induction. It can linear dose response is there. Again, linear quadratic is there. But whatever it is, linear or linear quadratic, but you have to be very note this point, the starting point. It all are NT, LNT or LQNT, non-threshold. That is why it is stochastic. So it starts from there. Linear non-threshold or linear quadratic non-threshold dose response curve for cancer induction. And risk models also developed for the determinant calculations from all these studies. Multiplicative risk model and additive risk model. I'm not going very detailed here. You can see in the right hand side graph, multiplicative and additive. The bottom graph shows the additive risk line, risk model. You can see that there is an age from 0 to x plus t. X is the point. This is x and this is x plus t. This is the latent period, and the effect will start from here. You can draw a sigmoid curve or linear curve here. Now, suppose this is the period where the exposure happened, let us assume. After certain years, the effect starts. Again, it increases, the probabilities increases with the age. This is the time or age. So in the additive risk model, this dashed line is the natural incidence. So in the additive risk model, because of radiation in every age, the certain additional risk, but that additional risk quantity is same throughout the age. But in the multiplicative risk model, this is the difference is bigger. As you grow on higher ages, that factor, the difference, is in a multiplicative model from the natural incidence. Natural incidence means the what we call that the natural cancer incidence, not because of radiation, the base values. So radiation-induced nominal cancer risk estimation in the latest ICRP, it is given as 5.5% per sievert. That means if 100 people gets 1 sievert of dose in a year, this is for whole population, which include everybody. 5.5% is people will get the risk. 1 sievert dose is a little bit higher dose. There is a possibility. Actually, it calculates like 1 in 18,000 for 1 millisievert. So if you convert to just multiply with 1,000 and take the percentage, the value will get 5.5%. For radiation workers, 4.1% per sievert for radiation workers. Of course, the risk will be higher for the whole population because of their age. There is no age restriction. There is no gender. Children, everybody is coming. This cancer risk is also, even though if he says 5.5%, this won't be same for everybody. There are a lot of confounding factors are there. Age of the exposed individual. Because if a person gets exposed at a lower age, or youth, or the elder age, the risk will be different. Sex, because and type of radiation, like where it is radiated, which organ, more high sensitive organ or low sensitive organs. These are all different factors which can differ the actual results. Another terminology that you see while studying this risk model is DDREF. DDREF. What is DDREF? Dose and dose rate reduction factor. Dose and dose rate effectiveness factor, EF. So this is something like, what is this means? DDREF is defined as the factor by which radiation cancer is observed from large acute dose should be reduced to the radiation is delivered in a low dose rate in a series of small dose fractions. This is exactly I discussed in the first slide of this cancer induction, because we don't have a real established curve for low dose and low dose rate. So it is taken as if you have the high dose probability, so that you have to take a DDRF factor is considered as 2. That means if there is a low dose and low dose rate factor, situation, then the probability will be half of that acute exposure. That is what DDREF REF says. Conclusion about radiation-induced cancer: single exposure can be enough to elevate cancer incidence several years later. There is no radio-unique cancer. You cannot say that this particular cancer comes because of radiation. This never come because of radiation, like that. There is nothing like that. Almost all cancers are associated with radiation, but breast, bone marrow, and thyroid are especially radiosensitive type of organs. So we can expect cancers more frequent incidence because of radiation for that. The most prominent radiogenic tumor is leukemia. So because of bone marrow sensitivity, and latent period is also different for different type of cancer. Age of irradiated individual is very important for evaluating the cancer. Another thing is the genetic effects. At low dose, radiation may cause damage to the germinal cells in gonads. So if there is no cell death happen to the germinal cells, then it is, if they sustain, but with a mutation, DNA damage, gene mutation, then it can, if DNA damage happened, cell is not died. It is, if it mutated, then if gene mutation happened, then there is an hereditary disease to the offspring's possibilities there. Animal studies clearly show that hereditary effect of radiation. Okay, but no hereditary effects have been observed in human population exposed to radiation. But we cannot ignore that also, because animal studies shows that we cannot do human being study for hereditary effects actually. So but we need to assume the risk for that also. There is a concept of doubling dose. Doubling dose, always sometimes you hear that in radiobiology, doubling dose, DD. DD, always you say that the value of DD is 1 gray. Again, this is estimated for mice, for animal, but they just take it to human being. They don't have experiments on human being, but they're just taking it for human being. Doubling dose value is 1 gray. What is doubling dose is, if give 1 gray dose, it doubles the probability of the natural incidence for hereditary effects. That means hereditary effects can happen not only because of radiation. There are so many other possibilities, so many other reasons. So if there is a natural incidence of hereditary effects, if that population get 1 gray dose, then there is a risk of doubling that probability. That is called a doubling dose. Okay. The risk factor has been again calculated from ICRP recommended value is 0.2% per sievert. Just like cancer induction is 5.5, 4.1 and on. Here 0.2% per sievert for member of public and 0.1% for per sievert for workers. The risk factor for genetic effect. And one second. Another important thing is in utero exposure. In utero exposure is what? In utero exposure is the exposure to the female during the pregnancy period. That is called in utero exposure. That is taken as in utero exposure. So here also very there are so many guidelines which are derived from the from various experiments and data, clinical data. Radiation-induced lethality and specific abnormalities in the embryo and fetus are depends on actually two things. Two factors are depending factors here. One is, of course, radiation dose, more effect. And the second thing is the stage of the development at the time of exposure, stage of the pregnancy at the time of exposure. That is also very, very important. If a pregnant lady get irradiated during the first few days, then they are more sensitive. So it is divided like 3 terms. First 1 to 10 days, or roughly 2 weeks, is taken as pre-implantation period. 11 to 40 days, like some up to 7 weeks, from 2 to 7 weeks, it is taken as, so 6 weeks it is taken as, or 7 weeks it is taken as organogenesis period. And third, from rest of the pregnancy period till the delivery, it is taken as the growth stage for the fetus. So if you see the radiation risk of these three stages, this is, you can see here, yeah, this is the risk that you can see, the effect of radiation in fetus. The first period, pre-implantation period, prenatal death is the most complications. And organogenesis, abnormalities, and neonatal death both can happen. And fetus period are less radiosensitive period compared to other two periods. Fetus are more safer, the third period. The other two periods are very highly sensitive. Now, in utero exposure, the threshold dose is also derived. Systematic studies on the effect of radiation on the developing embryo have been conducted in laboratory animals, and particularly mice and rats. And it is found that the experimental studies found that no damage to the intrauterine development of animal has been found for dose less than 100 milligray during the pregnancy period. So, in the studies of Hiroshima children, there is an evidence for a threshold dose of greater than 100 milligray. So 100 milligray is believed to be the safe, the ultimate safe level, the maximum safest level for during the pregnancy period, 100 milligray. The risk of, but always we always need to follow the alarm. The risk of several mental retardation increases rapidly to a value of 40% at 1 gray. If you go from 100 milligray to 1000 milligray, that is 1 gray, there is a high risk. There is a sharp increase in the risk, even the IQ shift of 40%. The later stage of pregnancy, maybe the threshold, you can even elevate the threshold from 100 milligray if you are at the fetus period or the last term. Fetal dose greater than 500 milligray, there can be significant fetal damage. The magnitude and type of which is a function of dose and stage of pregnancy. So according to ICRP publication 84, maybe even the latest updation, termination of pregnancy at fetal dose of less than 100 milligray is not justified based upon radiation risk. Less than 100, the termination because of radiation risk is not justified. Again, from 100 and 500, the decision should be based upon individual circumstances, depending upon their facility in the healthcare to provide the other mechanism and continuous evaluation of embryos and etc. And fetal dose, if you are sure that fetal dose is exceeding 500 milligray, there is a high risk of significant fetal damage. And termination is often a primary consideration if the fetal dose is exceeding 500 milligray. Usually, it won't happen, we know, as an occupational exposure, but if there is some therapeutic procedures, unfortunately, suppose the patient is undergoing, then it matters, especially in the abdomen or pelvic region. Another effect of radiation is lifespan shortening. Probably we may not much of bother about that. Many experiments have been conducted with animal after both acute and chronic exposure, and that show that irradiated animals die young. That is there. Figure shows that the relation between the lifespan, it is also non-threshold and linear. Human being, again, we don't have data, but just extrapolating to the human being, that's all. Another thing is the therapeutic ratio. The aim of radiotherapy is actually what? Everybody know. Need to give enough dose to the tumor and to destroy the tumor. And the same time, we need to spare the normal tissue as much as possible. The principle is usually illustrated by plotting two sigmoid curves. That are the two, that TCP and NTCP curve. Of course, TCP is tumor control probability, and NTCP is normal tissue complication probability, which is again, yesterday somebody was asking that. You can calculate it from there are so many equations for calculating. You can calculate from EUD equation, EUD divided by TCD 50 by gamma 50. And gamma 50 and TCD 50 are all radiobiological factors. That means these are all taken from the data or like the cell survival fraction studies curves or target theories and other LQ models and all. So purely a radiobiological thing, TCP and NTCP. Physical dose is also coming in the picture there. So suppose if you have these two curves, as you have seen in the diagram, TCP, better TCP value is greater than or equal to 0.95, 95% of TCP from the curve. You know that the curve, that point is going in the in the up way here, somewhere here, right? This is TCP and this is NTCP 90. This is suppose 100% and this is 95%. Okay, and this is suppose 0.5%, 5%. That is 0.5 and this is 0.95. Now, how it is separated, that is the important thing. So if you take at 50% level, if you take the TCP and NTCP value and take the ratio, that is called the therapeutic ratio. So, but always you don't think that your two curves will be like this, depending upon your tumor, where you are treating, the site of the tumor. Suppose your normal tissue is overlapping with the tumor, you never get a curve this much of separation. If your tumor is not very radiosensitive and normal tissues are highly sensitive, like certain have higher priority normal tissues, serial organs and all, you don't get this much of therapeutic ratio. So this curve can even come like this, etc. So that therapeutic ratio always depends on type of the tumors and the even you have certain methods, even addition of drugs, chemotherapy drugs, other methods you can use it for improving the therapeutic ratio, giving higher tumor control without much of giving higher dose to normal tissues. These are the different ways of improving the therapeutic ratio. The last topic of my presentation, time dose fractionation. This is quite a different thing. I will say what is the need of this first. Just to standardize the treatment schedule for a particular reason. Standardized treatment schedule, because you know that whatever we discuss radiobiology and all, finally what we are doing is we are doing the treatment, like patient treatment by using radiation. So you know the prescription dose, there will be a fractionated radiotherapy, number of fraction, dose per fractions, etc. So different protocol, different regimes comes there. Now we need to have established a relationship between the total dose, number of fractions, dose per fractions, etc. And we need to have certain methods, models to standardize the treatments for comparing different schedule, for adding from one treatment to another treatment, or just for subsequent treatment locations. Addition of doses, etc. So that is why the time dose models are being developed. Now, how it is being developed, that is an important question. That is why the importance here. So time dose models are developed, time dose theories are developed, clinical human tissue reactions, clinical data. Based on, we have a long experience of the treatment, actual treatment data, the experience, how much complication come to the lung because of giving this dose. Example, how much fewer the prognosis happened, this type of tumor, this much of dose, how this many of patients treated, how many were recurred, how many recurrence happened, how many were cured, etc. Clinical data, experimental animal studies, and very importantly, third thing, the cell survival theories, LQ models and other theories which is developed. These are all taken, and time dose theory has been developed. Of course, the cell survival data and all not taken for the initial concept, but now it is being taken very clearly. Why time dose model? Comparison of treatment schedules, modification of treatment schedule, development of new treatment regimes, retrospective analysis of clinical data. These are the important applications of time dose model. So various time dose models available. Strength, these are historical, not all, we don't use it now, just for the theory. He is the first person devised this scientific approach for correlating dose to overall treatment time. So he has put forward a terminology called equivalent single dose, EST. So equivalent single dose is equal to E total dose into some total dose into n raised to, what is that called, minus 0.33, plotted and take the slope in linear plot and taken as point slope and 0.33. Later on, there was certain correction. Then nominal standard dose concept came, that they have done slightly improved in this. In the EST model, there is only two things. total dose and number of fractions. But here, total days in the NST, the equation is equal to total dose into number of fraction into T. Of course, T has minus 0.11 and N has minus 0.24. So this T is the total duration of time. That is also very important to consider the overall efficiency, the overall performance of the treatment. So how much it prolongs, how much it goes. Because we know that we don't give radiation like 30 days, 30 fractions won't finish within 30 days. So that has been taken care in this NST model. And based on the NST model with a certain other curve fitting, the Orton and Ellis developed a time dose fractionation factor. They call it as TDF, time dose fractionation factor. Mainly, the input is taken from NST model. And the TDF equation they derived is TDF is equal to, you can see in my slide, 1.19, that is a constant, and d raised to 1.54 t by n raised to certain factors, minus 0.17. So this is the TDF factor. TDF factor, you know that some of the people are still using for gap correction, TDF technology. You can use it. TDF is nothing. It's a factor which is derived, which can, if you have your total dose, your number of fractions, and your total treatment days, you can calculate a TDF value for your prescription schedule. Now, if you have another treatment just after, suppose if you want to combine these things, you can again calculate. TDF is a linear thing. So you can do and you can combine and see how many total effectiveness or total number of fractions, what is the things you can do it. If you want to schedule in the reverse way, like suppose you want to increase your treatment day, you have to reduce your treatment days, then how much dose you need to increase because of this. Or suppose if there is a gap happened in the prescription schedule, so there is some loss of efficiency, loss of effectiveness. So you need to correct that. How much need to be corrected in terms of either in terms of number of fractions or in terms of dose per fractions. For these and all, you can use TDF. So I just show you, I think I have it. Yeah, TDF has been used for the gap correction. I think some of the people are still using, many people converted to the newest BED based method. I just want to ask somebody, is somebody using this TDF still from the audience? Anybody is using TDF for gap correction?
Yes, we are using.
Okay, yeah. So just an example here. If somebody is using like TDF equation is this one. For example, there is a 60 gray prescription for 30 days. This is your prescription. The dose per fraction is 2 gray. Now, what you have to do is you just calculate the prescribed TDF. 1.19 into number of fractions, 30. D is your, 2. Then T by N, total duration. You can take it as, because we treat 5 out of 7. 5 days in 7 days a week. So 7 by 5, or you can, suppose you have 30 fractions and 35, whatever, days total, take it the ratio here. Both will be same. Now, that is a prescribed TDF, you will get it. Now, because of certain reason, patient, after some 20 fractions, patient took a break of 10 days. Unintentional break because of certain other disease or certain other issues. So, because of this 10-day break, the actual TDF which has to be delivered, we need to the delivered TDF first. Then what you have to do is 20 days if treated means you have to calculate the TDF for 20 days. 20 days treatment is over. That is a delivered TDF. But because of the break gap, the delivered TDF is reduced actually. That efficiency is reduced. So you need to correct the delivered TDF with corrected TDF. You have to calculate. How do you calculate? That is a correction factor. Gap correction factor equation is T by T plus G all raised to 0.169. T is total days treated. For these 20 fractions, how many days are taken for? Maybe 25, this example. So 25 divided by 25 plus 20 raised to 0.16. You get some value of 0.9. Here we are getting decay factor is 0.988. Now the delivered TDF should be multiplied with the 0.988. So you will get 9 instead of 96.47, you are getting 95.4. That is the actual delivered. Effective delivered. Now then you from the prescribed TDF, that is 117 in this case, 117 minus 95, then the balance TDF is 22 you are getting. Instead of 20, example, you have to give 22 TDF. So 22 TDF example, then you have to either increase number of fraction or dose per fraction to balance and to get the 22 TDF. That is what the correction that we follow. So dose per fraction you can increase or number of fractions. Number of fraction, of course, you need to be in a integer like number. Sometimes you need to have an approximation. Now, there are certain limitations for NST and TDF. Single tissue, because this is a single tissue response assumption. If you see in this equation, nowhere it is mentioned for tumor, tissues, different type of radiosensitive parameters is not being taken care. Just the number of fraction, dose per fraction indoors. So actual radiobiology, alpha by beta values, cell sensitivity, nothing has been taken for this calculation. And is more or less empirical relation. NSD is an empirical, not derived from cell survival curve. And there is no distinction between early reacting normal tissues, late reacting normal tissues, nothing description. Because if you calculate TDF, just a simple number. You are not calculating for normal tissues, you are not calculating for tumor, you are not calculating for late reacting normal tissues, nothing. So that are the limitations still we were using, so many people are still using. I'm not telling it's completely wrong, but a better model with, because we are now following with the LQ model. So this is the new method, the time dose factor, the fraction, the model, another model, which is the biological effective dose. Instead of nominal standard dose, biological effective dose, BED. BED is, of course, it is derived from the most accepted cell killing model or cell survival graph, that is LQ model. So LQ model, yesterday we defined LQ model has survival fraction equation is e raised to minus alpha d plus beta d square, combination of two types of damages. Now, what will be the survival fraction after one fraction, one dose? Sorry? Anything? Okay, okay.
Continue.
So survival fraction after one fraction, 1 day. So e raised to minus alpha, I'm just putting small d. Dose per fraction is small d. Alpha d plus beta d square. After n fraction, survival will be e raised to minus n alpha d plus beta d square. Okay. Clear. Now, I'm just taking logarithm here. Logarithm just to remove exponential. Logarithm survival fraction is equal to minus also I'm taking here n alpha d plus n beta d square. Okay. So minus ln by alpha is L survival fraction divided by alpha is equal to n d plus 1 plus d by alpha by beta. This is the equation for minus ln sf by minus logarithm of survival fraction is equal divided by alpha is called alpha is the equation nd into 1 plus d by alpha by beta. Now this term is called BED. The full form is biological effective dose. So biological effective dose is equal to nd into 1 plus d by alpha by beta. So this nd is what? Number of fraction into dose per fraction. What is that? This is total dose. Total dose plus 1 plus d by alpha by beta. Even you can multiply, cross multiply, and you can get it 1 plus alpha type damage divided by beta type damage here also. So BED is biological effective dose is equal to, it is purely derived from LQ model. It is the total dose into relative biological effectiveness, relative effectiveness. So this is the equation for BED. So this BED value, if you want to calculate BED for any tissues, any tumor, normal tissues, anything, what you need to know the alpha by beta of that particular tissue. Otherwise, rest of the things are there in your treatment prescription. D, N, and all there. So if you want to calculate BED for any tissue, you can calculate it. Data is available with the literature. I'm not saying that is very perfect. It can vary a little bit, but this alpha by beta for tumor, different PTVs, different type of targets, normal tissues and all there. Yeah. Normal tissues actually for a different end effect it is defined. So BED commonly used for isoeffective dose calculation. BED is a measure of true biological dose delivered by a particular combination of dose per fraction. BED is not biologically equivalent dose actually. Whenever, don't confuse the BED by your prescription dose. If you calculate your BED for a prescription dose of 60 gray for tumor, alpha by beta 10, most of the time tumor and what is called, just a minute. Yeah. Tumor and early responding tissues, the BED, the alpha by beta value will be higher, 10 gray, etc. And the late reacting responding normal tissues, it is 3 gray. Even not exactly 3 for everything, 3.5, 2.5, etc. comes. Now, biological effective dose, if you calculate for 60 gray prescription, it is not 60. What about this? 60 into 1 plus 2 by 10. So 1 plus 2 by 10. 2 by 10 is 0.2. 1 plus 0.2, 1.2. 60 into 1.2 is 72 gray. For normal tissue, if you calculate, it will come 108 gray because that alpha by beta is lesser. So the value will be more. So don't confuse your prescription dose with BED. BED is totally a different one, biological effective dose. If you have 60 gray prescription, your BED is higher. Now BED, then why the BED purpose? BED you can equate the TDF for converting from one regime to another regime. You can calculate the BED of one regime. You can calculate another BED, then you can convert the fractionation and other things. It's a factor like TDF something. Okay. Now, there is another one which is called EQD, biological equivalent dose. Biological equivalent dose or EQD2, we call it as EQ2 gray dose. EQD2. Okay, before coming to that point, I will discuss just this slide. Clinical application of LQ model, just like TDF values, we can changing dose per fraction, you can converting overall treatment time, changing overall treatment time, gap correction, all these purpose you can use this LQ model and BED. These are some examples of calculation of BED for tumor. Now, whenever if you calculate BED for gap correction or for any other dose finding equivalent to gray dose or anything, always you calculate, you need to ask BED for what? BED for tumor or normal tissues at least. Then you need to calculate for both because both will be very different. Not like TDF. TDF, we never bother about tumor or this thing. Now, EQD2 I will discuss last. It will come last. Now, another important thing, whenever you go for gap correction in the world, these are very important. See, what is your BED? Your BED equation is equal to BED is equal to ND into 1 plus D by alpha by beta. Okay. This is taken as the effective biological effective dose now. Now, what happens in the actual scenario, especially for the tumors? If you are starting your treatment today, of course, the treatment is going to continue for another 30 days. In between, what happens? There is a tumor proliferation. Tumor repopulation is there. So this is not taken care in this equation. Actually, because of the proliferation of the tumor, of course, it depends upon the site, the type of the tumors, number of days, etc. But at least for certain type of tumors, there is a good proliferation. This will happen after certain days because of your treatment duration, because of your fractionation. Now, because of that proliferation, actual BED is getting lost. There is a reduction in the BED. So we call it as loss factor, actually. Now, how do you calculate that? For that, it is estimated that the proliferation number of cells, number of colonies proliferated is equal to N equal to N0 e raised to lambda T, not minus. Here it is increasing. Lambda is a constant. You can take it as the value is 0.693 divided by T potential. Potential is the potential doubling time of the tumor. I mean proliferation. The time is required to double that number of the tumor. So here, then of course, your BED equation also, you have to incorporate this in your BED equation for the tumor. So BED is equal to ND into 1 plus D by alpha by beta minus, because BED, the net BED is losing because of the proliferation. equal to minus 0.693 by alpha T by T potential. This T is the total treatment time and T potential is the doubling time of that particular tumor. So for the tumor BED calculation, you need to address this equation. If you are going for gap correction and all, you have to use this equation. There are certain exceptions, I will tell you that. So for normal tissues, there is also proliferation happens, but that is not going to worsen your situation. That is your extra benefit, actually. Repopulation is better in the normal tissues. Normally, we don't consider that. And proliferation is also is more in tumor, actually. And so that is the reason the loss of VED has to be included here. And again, you know, what is the, usually if you see the tumors, the head and neck tumors and all, where the more proliferation happens, this, the doubling will happen, it won't happen the day one onwards. It starts to, the tumor start to proliferate after 21 days or 28 days of the treatment. So that time is called the kickoff time, kicking off. So normally it is either 21 days or 28 days. So if your treatment finishes, the course of the treatment is finishes within 5 days or 10 days, you don't need to consider this term in your BED. You don't need to consider. Because you are going to finish before the tumor proliferation happens. So that is why the importance of SRS, SRT, SBRT, hypofractionated treatment and all, there is no loss of BED because no proliferation will happen. But conventional treatments, if it goes beyond 21 days or 28 days, whatever it is, you need to consider that. So this equation, maybe you can write T minus Tk. T is the total duration of the treatment and Tk is the kickoff time. If your kickoff time is 28 days and this is 30 days, even you can neglect, nothing is going to there. But because of certain gaps happen in the patient, instead of 30 days, suppose your treatment is going to 40 days or 45 days, then 40 minus 28. So you need to consider that loss of BED factor for the calculation. So that is the importance of the BED the actual equation of the BED. Now, comparison between two fractionation schedules. How do we do with BED? Comparison between two fractionation means, suppose we are going to treat a patient 30 gray palliative patient with 10 fractions. Dose per fraction is here 3 gray. Now, this is patient, because of some reason, doctor, clinician want to treat this patient for 5 days. We don't need to go for 10 days. We need to finish within 5 days. How much dose need to be given? How do you calculate? You can use the BED. BED should be same for every treatment schedule for that particular one. So 30 gray 10 fraction, use this and calculate BED. 30 into 1 plus D by alpha by beta. So 30 into 1 plus 3 by 10. You calculate BED. Now for 5 fraction, again you use same equation. ND into 1 plus D by alpha by beta. Here, suppose you get, what is the BED here? 1.3 into 30, right? How much is the value? 30 into 1.3, how much? 39, is it? So 39 gray is equal to ND into 1 plus D by alpha by beta. So here number of fraction is taken as 5. So you can calculate D. Simple. So dose per fraction, you can do it. And this is the one that I skipped, EQD2, equivalent 2 gray dose. That is also you can calculate with the BED. This is what we always do for converting tolerances dose and all. What is that equivalent biological equivalent dose or EQD, equivalent 2 gray dose? Same. Equation is same. BED is equal to ND into 1 plus D by alpha by beta. Okay. Now, if you have 30 gray prescription for 10 fraction, your dose per fraction is 3 gray. Correct? Now, what is the equivalent dose if I give a dose per fraction of 2 gray here? 2 gray, we believe that this is a standard fractionation style, 2 gray. So if I want to convert to the 2 gray dose per fraction, what is the equivalent dose of 30 gray? Definitely 30 gray will be different. How do you calculate? Same way you can use BED here. So BED, calculate BED of 30 gray first, 30 gray turn fraction. 30 into 1 plus 3 by 10 for tumor. Okay. Now is equal to, what is the EQD2? 2 gray equivalent dose. Just put EQD2 here. 1 plus 2 by 10. You are going to have two fractions. Sorry, 2 gray per fraction. So EQD2 is equal to BED value, which is this value, divided by 1.2, 1 plus 2 by 10. Correct? So 39 divided by 1.2 is your 2 gray equivalent dose. So this is the way you can calculate any fractionation to 2 gray. Suppose if you suppose this can happen so many times. We used to have this one. Suppose you have treated a patient long back, or you need to add that dose with the today's dose. How much is, suppose if you want to your external dose with a brachytherapy dose, you are going to treat CA cervix, and brachytherapy is going to 7 gray per fraction, and your external beam therapy is going to give 1.8 gray per fraction. So you cannot simply add these two total dose. You need to convert both into EQD2, then add it. Then you will get 2 gray equivalent dose for both. So these are the applications of BED. BED is also certain limitations. Alpha by beta value need to know, because the value which we obtained is not 100% correct. There are certain uncertainties related to all radiobiological constant, alpha by beta, gamma 50 and all, because derived from extrapolation of certain curves and all. And as we know, whatever the data is based on the model, LQ model or multi-target model, these models are not 100% correct. They can sometimes, they also behave little bit different from the actual one, because depending on the sensitivity of the tissues and all. And these are all the limitations of BED. So this is my final slide. So where are we now in radiobiology? Let us go back to our first day. You have the ionizing radiation. It comes and hit on the body, whether it's a treatment, whether it is anything. An occupational exposure is getting those, or any personal emergency accident or anything. Ionizing radiation is hitting on the human body. So two possibilities: ionization or excitation. And heat production is there, also there. Now, ionization, DNA damage. Excitation also can cause free radical formation and DNA damage. Now, DNA damage, what is the first thing? The first thing is enzymatic reaction in the body will be active and repair the DNA. Depending upon the extension of the damage, depending upon the dose, depending upon the tissue sensitivity, sometimes it will be repaired, sometimes it cannot be repaired. If it is not repaired, two possibilities. One is, mainly two possibilities: cell death, otherwise DNA mutation. Chromosomal aberrations and all convert, either persist there or it can convert to mutation. Now, cell death happens, cell killing happens. If repair is not there, cell death happens. Then it can be a early acute effect, like what we discussed, NBD syndrome, bone marrow syndromes, etc., etc. Or it can be a late effect, something like a somatic cancer induction, cataract, etc. Or it can be a development effect, like suppose a pregnant lady gets in utero exposure, then it's a developmental effect. That is the way of cell death happens, cell killing progress. Now, the DNA damage is not going for a cell killing, rather than it is going to a DNA mutation. Then depends where it is getting mutated. If it gets mutated on somatic cells, malignant transformation, cancer induction is also there. If it is going for germinal cells, hereditable effects can happen. So these are the possibilities of interaction of ionizing radiation with the living being, and that is the whole story of radiation biology. I'm not arguing that I have not covered the full topic. Never. I cannot do much within this period of time, but I try to cover most of the topics that we have learned as in our syllabus. Of course, that may be used for the Argo exams and other purpose. Thank you so much.
Yeah. Thank you, Niyaz. Thank you, Dr. Niyaz. So it was very insightful and very enlightening, and you have covered almost all things related to radiation biology.